Hello. I just was telling Dr. Bland that I really shouldn't have listened to his talk, because now my mind is just out there somewhere. I love it. I didn't want to miss it. But yeah, I'm happy to be here. It's my first time in UK. And I'm looking up at all the buildings in London. It's quite amazing. And glad to be here. I'm glad to be invited. What they wanted me to talk about, no introduction, so I'll just say I'm a professor at the National University of Natural Medicine in Portland, Oregon. Been there for 22 years full-time, and I'm a naturopathic physician, which in the United States is family physician, primary health care, and my specialty is functional gastroenterology. And that's everything I teach and lecture about and write about. So they asked me to come talk about a very central concept in gastroenterology that spreads out, of course, to every other system in the body, which is how what most of us didn't think about for a long time, which is the bugs in the small intestine, because the small intestine has a low count, normally less than 10 to the third in a gram of material, compared to the billions that you might find in the large bowel. So all of this research that we look at, all of this microbiome DNA studies, these are all large bowel. Stool is what's living in the large bowel, and maybe perhaps the left side of it. And maybe not even what's living there, but what's in the stool, which is moving through the center. It's not really what's in the lumen, but it's not necessarily what is right up against the membrane, and it's not what's in the dense layer or in the not so dense layer of mucus. So what I'm going to talk about today is the bugs in the small bowel when they overgrow, and how that is the underlying cause of many of the inflammatory states that we see. And then later today, Joe is going to talk about the endotoxins, lipopolysaccharides, and how that mechanism fits into this whole toxicity that occurs in the overgrown bacteria. All right. How many of you already work with and test for and treat bacterial overgrowth in the small intestine? Okay, so maybe a third of the people. So I hope that you'll learn some new concepts from me about that. And for the ones that don't, I hope I will more than introduce you to how to approach this and why it's important. And as Sarah said, Alison Seebecker and I have created a lot of this material together. We teach advanced gastroenterology at NUNM, and so some of the slides we've co-created the content. I found out I never used to put a lot of pictures in, but something didn't happen in this room that normally happens. Normally when I put that on, everyone says, "Ah." It didn't happen. Maybe it's an American phenomenon. It happened in Australia, actually. New Zealand, I think, too. Oh. Anyway, maybe you just weren't warmed up yet. But this is a baby cheetah, and I think he or she is very cute. There you go. All right. So small intestine bacterial overgrowth, it's really a misnomer because they're not just bacteria that are overgrown. They can also be archaea. And of course, you can have SIFO, or small intestine fungal overgrowth. But we're going to focus on the bacteria and the archaea today to keep it simple. And this is not new, because the first writings, 1955, was a writing about, it doesn't look like it's about bacterial overgrowth, but it was. This one, intestinal pseudoobstruction with bacterial overgrowth, 1969. And the term blind loop syndrome that you see on the bottom here is another name or an older name for bacterial overgrowth of the small bowel, SIBO. So if you put them all together, we've got over 2,075 articles the last time I checked, which was, I think, 6 months ago. And Sidney Haas was a pediatrician in New York who came up with something that was called the banana diet for fun, but what he actually called it was the specific carbohydrate diet. And it was really a diet to treat celiac disease, but he didn't realize at that time what caused celiac disease because gluten wasn't discovered until 1951. So actually 1952, the year after he published the book. And so he went from being really famous as a physician that had managed to save millions of people from sure death from celiac disease before they knew what caused it, to being kind of a known nothing in particular, because when they discovered gluten, they said, oh, you can just have a gluten-free diet. You don't need to do this other diet. But Elaine Gottschall had a daughter, I believe it was, whose GI condition, probably Crohn's disease, was cured by Dr. Haas's diet and treatment from Dr. Haas. And so she said she really wanted to keep this diet from being lost. And so she further researched the carbohydrates that were safe in that diet and created the book, Breaking the Vicious Cycle. So she maintained that for us. Because hardly anybody has seen Dr. Haas's book. It just kind of disappeared after the 1950s. 1962, the Quintron Corporation started making the machine that we use, the breath tracker that we use to measure hydrogen and methane in the breath, which is the way to, the practical way to check for SIBO, as opposed to a duodenal aspirate culture, which is harder to get, but that's been available since the 1950s as well. So bacterial overgrowth of the small bowel is not a new condition, right? 60, 70 years old, that we are well aware of it. Since 2014, I've gotten really interested in the question that a lot of people and physicians and health practitioners ask me, which is SIBO. You just have to keep treating that over and over, right? Because it keeps coming back. Well, that's absolutely true. Unless you treat the underlying cause. So I've been really focused on underlying causes for the last 4 or 5 years and starting to put together a list of the more common ones. And I really want to make a button. I keep saying I'm going to do it, but I haven't done it. A button that has the international no sign on it. No, it wouldn't say that. It would just say endometriosis equals SIBO. Did you know that? This is the most common underlying cause that I see for SIBO in people who have uteruses. It's a massive cause. And we'll talk a little more about that, but you'll notice it here under adhesions. Because if you have monthly bleeding into your peritoneum, that's going to cause some adhesions. And it can be pretty massive. It just depends on the case. It depends exactly where the endometrial rests are, where the bleeding is occurring on a monthly basis. Just to pick out one thing, that's a big one. Somebody called me in a year and asked me if I ever made those buttons. Traumatic brain injury, changes in permeability, changes in villi length and loss of villi and fusing of villi and erosions and ulcerations, all within hours and days of traumatic brain injury. And not even the kind that gets people in the hospital where they have to cut out a slice of bone from the skull to allow for swelling, but even the kind that doesn't make people stagger around after it happens, but they just got a real shaking of their brain. Food poisoning, traveler's diarrhea, or gastroenteritis, whatever you want to call it, there's a 10% chance of getting post-infectious IBS, which is basically hydrogen SIBO, which we're going to talk about. So, I mean, the list goes on and on, but good to know that some of the most important protective factors, should I be using a pointer? Because you can see what I'm doing, but right in the middle here, we've got hypochlorhydria under traumatic brain injury. We've got hypochlorhydria, pancreatic insufficiency, bile or brush border enzyme deficiency. These I call the upper gate of the small intestine. These are the normal secretions that come into the duodenum and normally help to reduce overgrowth of bacteria, just control the growth. It's one of the major reasons why the upper GI tract, the small intestine, has very low numbers of bacteria, as opposed to the colon where we should have billions per gram. A lot of people, as you know, and if you're doing functional medicine, don't make enough of these things. And when we help them to make more, that's going to help reduce their risk of bacterial overgrowth. All right. I think I will not get stuck on this slide. Here's a list of underlying causes if you didn't like that graphic design that I have. Here's another way of looking at it. You can take a look at that. And of course, there's medications as well, especially antibiotics and especially opiates and proton pump inhibitors. Very common medicines where I come from. I wanted to go back here for a second. I mentioned here altered collagen over on the left, Ehlers-Danlos syndrome. This, in the United States, in the pure form, the form that fits all the diagnostic criteria, probably only affects about 2% of the population. I see a lot of it, though, in my practice, just because it causes a lot of digestive disorders and rheumatologic disorders. And you might think of rheumatologic disorders leading to digestive disorders because of the medications people take for the pain, whether it be opiates or NSAIDs, which are very damaging to the GI tract. But just to show that's an important piece there. And we might find that people have hypermobility type Ehlers-Danlos syndrome and hypermobility-ish or Ehlers-Danlos-ish tendencies, even if they don't meet all the criteria. And that means that they have more mobility of their joints, and that's part of the Baton score that we use to test for it. But they also have loss of tone and floppier internal organs. So here's a barium film showing here the stomach hanging down to the pelvis. That's the first one, A. B is showing the entire small intestine filled with barium fallen like a basketball into the pelvis. Not where it belongs, all of it in the pelvis. I mean, here's the pelvic brim right here. Here's the iliac crest above the small intestine. And then, of course, you can see transverse colon prolapsed as well. Here it's completely prolapsed. So instead of that beautiful, pristine transverse colon that you see in all the books, instead it's like this. That makes a difference in how things flow. And it makes, when flow is changed, that makes a difference in bugs, which again brings us to SIBO. Definition would be an abnormally large number of bacteria or archaea in the small intestine, which does change digestion and absorption and can have systemic inflammatory effects as well. We still tend to talk about Rome 2, which we're now at Rome 4, criteria for functional GI disorders, but we like to talk about Rome 2 because it includes bloating for IBS. Bloating sort of got taken out in Rome 3, and so a lot of times we'll use the Rome 2 criteria because bloating and abdominal gas distension is a big part of this disorder. Occasionally you see people that have a real six-pack abdomen and they don't show much distension. They may have pain and discomfort because there's a lot of gas in there, but it doesn't cause them to have distension because their muscles are in such good tone. So don't be fooled by that. But constipation, diarrhea, abdominal pain, and bloating, those three changes in stool, pain, bloating, those are the three main GI findings. These are opportunistic or beneficial organisms. They're not pathogens. They're just overgrown. And they could be oral, small intestine, or colonic flora. It's all about the location. So I mentioned 10 to the third small intestine, 10 to the third microbes per ml or less. And hydrochloric acid, bile, enzymes, the gut-associated lymphoid tissue, and the migrating motor complex of movement keeps this all in check. Large intestine, 10 to the 11th per ml. And that's the way it should be. But when it starts to look like that in the small bowel, your patient has all kinds of problems. Oh, your client, patient, whoever is in front of you that's consulting you. There are lots of over 40 disease associations that have been well proven with SIBO in the literature. These are some of them. You'll notice hypothyroidism is a big one and diabetes is a big one. So that means this is a common condition. In the United States, it's a general estimation there are 30 million people that have SIBO. Scleroderma, not a very common autoimmune condition, but if your client or patient has it, they pretty much can't get out of having SIBO because of the stiffness that occurs in the gut and the change in motility. Mark Pimentel is a gastroenterologist at Cedars-Sinai in Los Angeles, California. And he and his group have done a lot of the research getting this to where it's better known. And one of their studies, 84% of patients with irritable bowel syndrome also were positive for small intestine bacterial overgrowth. If you thought it was a colon condition, irritable bowel syndrome, it's not. And then when they treated those folks, 70% of those whose breath test normalized after treatment had improvement in symptoms. We kind of go for 80 to 90% improvement in symptoms. That's kind of our goal. So I have this series of little light bulb slides. If you forget everything else from the lecture, just look at the light bulb slides. They will give you, I like to say that when our worldview is breached, we tend to ignore things. So in other words, since I assume your perspective and my perspective, I know, is that, for instance, antibiotics, this is an abbreviation for antibiotics. Antibiotics, we tend to think that they cause GI upset because they unbalance the flora. So if your patient or client comes in and says, you know something interesting, I took Cipro for my my bladder infection and my IBS went away, like almost completely for about a week, and then slowly came back. And by 2 or 3 weeks, it was all back. Isn't that interesting? Well, you know, if your worldview, like mine, is that antibiotics disturb the biome, that information goes right over my head. I don't even write it in there because it doesn't make sense. I hope you don't do that. When a patient reports dramatic transient improvement in their IBS or other GI symptoms when they're taking an antibiotic for some reason other than GI condition, you have to think about this because it cuts down the numbers in the small bowel for a short time, and then they come right back because you didn't treat the cause. The next one is when a patient reports worsening GI symptoms from probiotics, especially those that contain prebiotics. Whoosh, right over our heads because we're not thinking that way. That doesn't make any sense. Well, it does make sense when we look at the fact that prebiotics are there to feed bacteria, and whether they're in the large bowel or the small bowel. And also because one of the probiotics that's most commonly used, at least in the United States, lactobacillus, that's one of the organisms that can be overgrown in the small bowel. So no one's really done a study that I've seen saying that the people that really get worse from lactobacillus are the people who already have overgrown, but could be. Here's another one. When patient reports fiber worsens their constipation or other GI conditions. Whoosh. Boy, that's going to go right over your head. I hope not, because fiber is food for bacteria to make short-chain fatty acids, right? Short-chain fatty acids can be really irritating to the small bowel. They're made to be in the large bowel because we don't have large amounts of bacteria normally in the small bowel. So they often say, everybody tells me to take more fiber, drink more water, but it just makes my constipation and my bloating and my pain worse. That's an important key that should make you think maybe there's overgrowth in the small bowel. When a celiac patient reports insufficient improvement from a strict gluten-free diet, or you can blame them for not doing the diet right. There's got to be something you're still getting. Now, maybe they are. But once you've got that figured out, celiac disease is one of the comorbidities, goes along with SIBO. So, and we know that food poisoning, especially bacterial food poisoning, dramatically increases the risk of getting celiac disease within the next 2 years. So there's a big correlation here because food poisoning is also a big risk factor for SIBO. So if the patient has both celiac and bacterial overgrowth, which often is the case, take away the gluten, but they still have the bacterial overgrowth causing bloating, pain, diarrhea or constipation, and systemic symptoms. So they don't really get that much better. You have to treat them both and treat the cause. Proton pump inhibitors, we said that gastric hydrochloric acid, as it leaves the stomach and enters the duodenum, is a big factor for down-regulating bacterial growth, and we need it there. When a patient develops chronic GI symptoms after taking opiates. So I always ask my patients, I get a lifetime history of antibiotic use and a lifetime history of narcotics. And people forget that, oh, yeah, I guess I did have narcotics during that surgery and after, before and after that surgery. Oh, maybe that appendectomy, maybe I did get some narcotics. And you add it up. Each time someone takes narcotics for a portion of a day or a full day or longer, the migrating motor complex almost completely stops moving. That means you've got 18 to 20 feet of small intestine loaded with food, especially carbohydrate, which the bugs love to eat, and bacteria 10 to the third, but they're not going to stay at 10 to the third very long when you stop all movement. pretty much stop all movement. Stress does a very similar thing. High stress slows down or stops gastric and small intestinal movement. So stress is definitely a big factor too. When a patient develops chronic GI symptoms after taking long-term broad-spectrum antibiotics, we all see this in our practice. If you ask about lifetime history of antibiotics, in the United States anyway, often people say, you know, a few times when I was a kid. Did you ever have acne? Oh, yeah. Did you take any pill every day for acne? Oh, yeah. Oh, yeah, right. I guess that was an antibiotic. Tetracycline. Yeah, I took that every day for about 4 years. People with chronic low ferritin or serum iron, whether or not they have iron deficiency anemia, you have to think about this condition. Bacteria love iron. They love carbohydrate and they love iron. And they will steal it for their own metabolism. That's why we have lactoferrin in all the secretions of the GI tract, to kind of cull the iron out so that the bacteria don't overgrow. One of the reasons we have lactoferrin. So take this as, I mean, we can make another button. Low iron equals S, but there are other things that can do it. When a patient develops post-infectious IBS, and we're going to talk more about that, the details of that, but like I said, there's statistically about a 10% risk of developing SIBO and post-infectious IBS after each attack of food poisoning or traveler's diarrhea. I had one woman come to me who had very intense hydrogen SIBO. Her peak hydrogen was actually 140. Anything over 20 is high. And I asked her about food poisoning, traveler's diarrhea, or gastroenteritis, and she said, oh, at least 50 times. She spends a lot of time in India. She lives there for months at a time. She goes all over the world, and she's just had food poisoning over and over and over. She's doing really well now. So after an enteric infection like this, about 10% in this study got post-infectious IBS after a bout of bacterial food poisoning. And veterans that are in Afghanistan or Iraq have a much higher risk just because they get so much food poisoning. And these are some of the more common organisms at the bottom that are a big risk factor for post-infectious IBS. Campylobacter is kind of like the poster child bacteria, if a bacteria can be a poster child, for this condition. Viral gastroenteritis, lower. Also lower risk of developing celiac disease compared to bacterial. But all of these are really common causes, of course, of food poisoning and traveler's diarrhea. If you think that there aren't any biopsy findings in post-infectious IBS, there actually are. And the big one is increased rectal lymphocytes if you do a biopsy of the rectum. But nobody does that, really. But if you did, that's what you tend to find. So post-infectious IBS may actually just be classic SIBO type D, diarrhea type. So these are, again, some of the more common overgrown organisms in this condition. Anaerobes on the left, including lactobacillus and Clostridium. On the right, we have the aerobes. So E. coli is there, Klebsiella, Proteus. Now remember, if you do any stool culturing, it doesn't give you any information about this, right? Like I said, everything we talk about most of the time is large intestine flora. Here we're talking about small intestine flora. Stool's not going to tell you anything about that. You either need duodenal aspirate culture or, more simply, a breath test. Interstitial cells of Cajal are the little individual cells that are scattered throughout the mucous membrane in the small bowel. Actually, in any organ that has stretch or movement, lungs, skin, many other organs. But interstitial cells of Cajal, or ICCs, are reduced after Campylobacter jejuni food poisoning. And this study showed that 3 months after Campylobacter gastroenteritis, 27% of rats that were given Campylobacter, they developed SIBO. And these rats also had, as it says under there, a lower number of interstitial cells of Cajal that corresponded to that in the jejunum and the ileum. And there's actually a number, 0.12 ICC cells per villus was the threshold. If they had destruction of more and more of these interstitial cells of Cajal, they developed bacterial overgrowth. So at the top, we see a control rat, and each of those little arrows points to an interstitial cell of Cajal. So here on one portion of a villus, we're seeing 5 interstitial cells of Cajal, pretty close together. That area is going to have good motility, all other things being equal. These are all the same magnification. So B in the middle is a rat that got the Campylobacter that did not develop SIBO, because only 27% of them did. We always want to look at the ones that didn't, right? See why. But so here we still see 2 interstitial cells of Cajal present. Rats exposed to Campylobacter that developed SIBO and a real reduction. Here we only see 1 at the same magnification. So that was the mechanism. So what's going on? Why are the interstitial cells of Cajal going away? Well, every one of these organisms that we said are common causes of SIBO produce, the bacteria especially, produce cytolethal distending toxin B. They contain this toxin, and it does them good to secrete it, makes their milieu more favorable for them. But it turns out that this toxin, cytolethal distending toxin, when it's deposited in the GI nervous system and the interstitial cells of Cajal, it, by molecular mimicry, it also reacts against vinculin, and anti-vinculin antibodies develop as well. And those cause autoimmune destruction of the interstitial cells. So this is kind of the underlying mechanism of where we get a slowing down, slow enough that the bacteria aren't being flushed through by the migrating motor complex that normally flushes from the stomach all the way down to the ileocecal valve. Campylobacter jejuni, as I said, is kind of the prototypical bacteria that produces this toxin. And like I said, vinculin is a cytoskeletal protein that is there to allow cells to stretch and connect. And bacteria that form this toxin can also trigger that anti-vinculin antibody, which leads to the destruction of those cells. They're like little pacemaker cells. You know, it's not the vagus nerve, it's not the parasympathetic nervous system, but it works as a local pacemaker, just like the heart has pacemakers, to stimulate this wave through the 18 to 20 feet of small intestine. So I like making little diagrams like this. So I've got Campylobacter jejuni up at the right in the bubble, and its toxin, cytolethal distending toxin B, triggers, along with antivinculin antibody, damage to those interstitial cells of Cajal, which leads to post-infectious IBS. And in human studies, it occurred about 10% of the time after, like you have a 10% chance of getting this each time you have food poisoning. So my patient who had 50 cases, it made sense. I mean, she was bound and destined. Here's another list of bacteria that produce CDT. And there's going to be intestinal hyperpermeability that occurs from this as well. So food poisoning on the left produces CDTb. The bacterial toxin leads to autoimmunity in the gut and in other cells, but especially in the gut today, we're focused on that, leading to nerve damage, interstitial cells of Cajal, some of them go away, and that leads to SIBO, which causes all the symptoms of post-infectious IBS. And you get GI symptoms from the pressure of the gas, and you get interference with digestion and absorption, but also systemic, which Joe is going to talk more about with the endotoxin, systemic symptoms and diseases from the complications of hyperpermeable small intestine, bacteria translocating, their toxins getting into the systemic circulation, and malabsorption of essential nutrients. So this is the only slide I'm going to show of LPS. Joe's going to follow up on that later. But here's a gram-negative bacterium over on the left. If you cut out a little piece of the cell wall, it looks like some kind of Jell-O dessert. And if you enlarge that over here on the right, it looks like a bunch of mice eating cheese, and all you can see is their butts and their tails. And that is lipopolysaccharide, the little mouse, the little bit you can see of the mouse. And it's in the outer membrane of the cell wall of gram-negative bacteria. Gram-positive bacteria have peptidoglycans as well, which can also cause this kind of systemic inflammation. But Joe will talk about how absorption of excessive LPS from the gut because of bacterial overgrowth in the small bowel, which is where everything is so well absorbed, not so well absorbed in the large bowel perhaps. This is a trigger for all kinds of systemic inflammation, which Dr. Bland was talking about earlier as a cause of all disease, modern disease. Again, these are the physiological factors that prevent bacterial overgrowth normally. The upper GI secretions, I call it the upper gate of the small intestine, just to make it sound poetic. And mucosal associated lymphoid tissue goes along with those secretions. A little more detail about the brush border enzymes includes, the disaccharidases and peptidases, the fine tuning of digestion. Having normal GI anatomy, now we saw in Ehlers-Danlos syndrome, that was not normal anatomy. You also don't see normal anatomy in things such as diverticuli. Whenever you have a diverticulum, here's one off the small intestine here, shown with a barium study, but here's the normal lumen, and then this outcropping. Here's multiple diverticuli. These are great places for bacteria to hide from the migrating motor complex. and from the different secretions that normally impede their growth. So whenever you have a little blind loop, a place where the bacteria can get out of the flow, they're more likely to overgrow. And like I said before, the mucosal brush border on the microvilli, this is where the diamine oxidase for histamine detoxification, this is where the disaccharidases for breaking down disaccharides, which are the favored foods of these bacteria. They can break down disaccharides just fine, even if your patient or client can't. So you want to make sure that your client can break it down first before the bugs get to it and get overgrown. And again, over on the left, we have a photomicrograph of villi in the small intestine, which give it so much absorptive surface. And then over on the right, electron micrograph that shows the microvilli, the invisible microvilli. And I always, with my patients, I always say, if my fingers were epithelial cells in the small intestine, what did I say? If my hands were cells, and they had a tight junction between them, they have villi, which means fingers, and they have microvilli. If you imagine that my hands are totally covered in hair, just little hairs all over all sides of my hands, those would be the microvilli. And that's where the disaccharidases are, the enzymes for breaking down the smallest particles of sugar. If we don't digest them properly because there's been damage from food poisoning or celiac disease or some other condition, then we're not going to have those enzymes. And the bugs get all the sugar, and your client gets none of it, which causes overgrowth. So really important to have a good brush border. And then lastly, of all the things that help prevent overgrowth, normal motility in the small bowel. The migrating motor complex, or MMC, sweeps undigested food and organisms to the ileocecal valve. Anything that slows that down, those are like the main things that cause SIBO. So upper gate, I could use that guitar right now, I think. I like to sing. Did I mention? I like to sing when I lecture. And I take songs that are perfectly good, and I ruin the words, but they're funny. Thank you. So migrating motor complex occurs between meals when you're fasting, 4 to 5 hours or more after not eating. And Jeff Bland talked about maybe not eating for 16 hours a day. That's a really good way to improve the migrating motor complex, give it longer time to work. Because it's not going to work for the first 4 to 5 hours after you've had a meal, a dinner. So overnight, it can really go gangbusters. So every 90 minutes, sweeps from the stomach to the ileocecal valve. And you can see the details of how much is moving and how fast it moves. It's generated by the enteric nervous system, myenteric plexus, and also motilin. Motilin is a very important neuropeptide in the gut it's aptly named motilin for migrating motor complex. And it stops when you eat. So that's the magic of not eating for at least 5 hours. Also, if you can get your clients to not snack all the time, if they don't need to maintain their blood sugar, having them go at least 4 to 5 hours between meals is another way to get a little bit of migrating motor complex activity between each meal. So here's the first verse about this. Oh, I ruined a perfectly good song by Chuck Berry, which is called Roll Over Beethoven. but I call it rollover intestine. The MMC is a real kill. So let me try that again. The MMC is a real keen thing to have. Sweeps from the stomach to the ileocecal valve. It starts when you're fasting, stops when you swallow a cab. Migrate motor, migrate motor, migrating motor complex, migrating motor, migrating motor complex, migrating motor, migrating motor complex, migrating motor, migrating molar, roll over intestine, give my enteric the news. Thank you. So the motility in the small and the large intestine is dependent on different things. They're very different. Don't think of the bowel, just everything moves. They move for different reasons. So we see that in the small intestine, bowel movements are not related to migrating motor complex. That's just moving things through to the ileocecal valve, right? Sweeps from the stomach to the ileocecal valve. Just sing that whenever you can't remember. In the large intestine, and that's fasting, in the large intestine, bowel movements are caused by what we call mass movements that are triggered by eating, by distending the stomach with food or liquid. So bowel movements can occur up to 6 times a day, supposedly, with normal function. And it's a high amplitude contraction that actually moves things through, especially through the transverse and down. And it's triggered by reflexes like the gastrocolic reflex. In this case, stomach distension, stimulating the colon to move. And that's the second and last verse of my little song. Because this is my song about my favorite GI reflexes. The pressure is rising, just follow the rhythm of chyme. There's gastric distension, getting colon ready to prime. Roll over, dear colon, reflexes are here at this time. Gastrocolic, gastrocolic, gastrocolic reflex, gastrocolic, gastrocolic reflex, gastrocolic, gastrocolic reflex, gastrocolic, gastrocolic. Roll over, dear colon, give my enteric the news. Which takes us to adhesions. So adhesions are sort of this invisible, they're not invisible if you're actually looking and feeling, but in medicine it seems like adhesions, they're a real thing, but they're sort of ignored. Because what are you going to do about them? If you go in surgically a second time, if they were caused by surgery the first time, and lyse the adhesions, that just stimulates them to grow back, sometimes even more. There's an old book in our library called Medicine's Deadly Dust. And it's about the concept of talcum powder on surgical gloves. Any place you touch, you get an adhesion. They've just in the last few years finally got most of the talcum powder out of sterile gloves and non-sterile gloves, but it kept them from sticking together in the box. But a lot of them actually come in individual wrap packages, the sterile ones, so I'm not sure why they had those, but finally they're getting that out. But it turns out that opening up the gut, whether it's laparoscopic surgery or open technique, injecting different gases to improve the visual field. Any kind of touch, whether it's a metal instrument or a glove, even without talcum powder, can lead to this kind of adhesion. So here we see adhesions are on the outside of the organ. They're on the visceral parietal surface, visceral peritoneal surface. So here's a band of tissue not normally present that's attaching two loops of small intestine. When that happens, it changes the configuration. Normally, you have a nice smooth loop of small intestine that hangs in from the mesentery, numbers of them. And if you create a hairpin turn or even a right angle turn instead of a nice smooth curve because of an adhesion, or if an adhesion wraps around and narrows the lumen by constricting it, you slow down the flushing of the bacteria. And these are like the diverticuli that we saw before. These are going to be good places, permanent good places for bacteria to grow. So you take Cipro for your bacterial infection, dramatic improvement in your gas, bloating, and pain and diarrhea or constipation for a week or two, and then it all comes back because you've got these in place. Whatever it is, whatever underlying cause is there, this is an important one. And this is where endometriosis comes in too. Another important piece I like to call the lower gate of the small intestine, or the ileocecal valve. A functional ileocecal valve is mostly one way, from the ileum over to the left to the cecum, ileocecal flow. There is some reflux. When we talk about reflux, we're always talking about gastroesophageal reflux. But there's bile reflux, and there's what we call ceco-ileal reflux. So instead of things going from right to left, they can go from left to right, ceco-ileal reflux. Think about that. So we said you have, 10 to the 11th per gram bacteria in the large intestine, which includes the cecum. If that's refluxing through an ileocecal valve that doesn't stay fully closed, because that's really its normal steady state. It only opens when things need to move through with the gastroileal reflex, which is one we didn't sing about. That's the third verse. I'm not going to do that one. But if you get reflux back this way, you get 10 to the 11th per gram moving into that low bacterial load system. And that's one way that colonic flora could cause this. I've had patients who, because of a dental abscess, we swallow at least a liter of saliva a day if we don't have Sjogren's syndrome, or if we're not on the stage in front of a lot of people and our mouth goes dry. And so we're swallowing all the bacteria that's coming off of that dental abscess. And I've had patients who that's all we needed to do, take care of that. That sometimes is a big job. And then treat their SIBO, and then it's really, really good. So it can be oral bacteria. It can be colonic bacteria. It can just be small intestine commensals that are overgrown. Normal blood sugars are another very important piece, probably for a lot of reasons. I could really nerd out on all the possible mechanisms, but let's make it simple. We know that diabetic autonomic neuropathy changes motility in the gut. So constipation and diarrhea are very common things in diabetic autonomic neuropathy, right? Not the peripheral neuropathy that causes the pain in the extremities. And I find that even in patients with prediabetes, it doesn't have to be over a certain line. If they have insulin resistance, they're going to have more of a tendency for changes in motility, and perhaps even the amount of sugar that's secreted into the gut through the lumen, through the wall. So we're going to take a little break pretty soon, but I just want to introduce this concept. Am I out of time yet, or I have a minute? Okay. So 2 phases. I just always like to point this out because we're really focused on pancreatic enzymes, but sometimes we forget about the brush border enzymes. And this is really important in SIBO, both of them. So pancreatic enzymes and bile, first phase of digestion in the small bowel. And then the brush border enzymes when it gets right up to the microvilli. In the brush border enzymes, there are peptidases. For our purposes today, they're not quite as important because the bacteria don't really thrive on amino acids. But disaccharidases, help break down disaccharides to monosaccharides. And if we can do that soon enough, then the bacteria and the archaea don't get as much food because they live on the sugars, the monosaccharides. And like I said, if your patient or client has a disaccharidase deficiency, like lactose intolerance, or a sucrase deficiency, maltose and isomaltose to break down starch, those can all be deficient. By the way, you can, my strong recommendation is if you have a patient with problems like this in the GI tract and they're going to have an upper endoscopy, either you're referring them or they're going in for one anyway, you might ask, pretty please, would the gastroenterologist freeze a biopsy sample from the duodenum and have it analyzed for disaccharadases. So you can test directly for disaccharidase deficiency by a frozen biopsy from the duodenum. And if they're going in there anyway and they're taking biopsies of other things, might as well do that if you suspect this. Really important information, because if they have disaccharidase deficiency, they will continually have SIBO. You'll do all these wonderful treatments. They'll get so much better for a month, and then it all comes back. Sometimes only during the time they're on treatment. They feel wonderful, and then as soon as they stop the treatment, it's coming back. So remember, bacteria, they can make so many wonderful things, and one of them is glycosidases, which break down the brush border enzymes because they're glycoproteins, and it liberates sugar for the bugs. They just, it's all about me. It really is the me generation when it comes to bacteria. But they do quorum sensing, and they have a lot of cooperation as well. But in this case, they want to get sugar. Girls just want to have fun, and bacteria just want to have sugar. They may also, the glycosidases may also digest the glycocalyx itself, which is that in the unstirred layer of material just surrounding the microvilli, which is where a lot of these enzymes are kept. And I think that's a good place to take a break. Thank you.